Thank you very much. Good afternoon. My presentation is on situation analysis of NTDs in Nigeria. I will start by introducing what NTDs are, but I won't waste time on this because most of us know this information. Okay, so I'll keep most of them. Global and national responses to NTDs are lax because NTDs affect the world's poorest and most vulnerable populations and drive people into even deeper poverty. And these are normally missed out when health agendas and budgets are set and are not even mentioned in the Millennium Development Goals. NTDs are identified, 17 NTDs, we've had that, and the infections can be either helminthic, protozoan, bacterial, fungal, or ectoparasitic. So the Nigerian situation, elephantiasis and river blindness are more common in Nigeria than any other African country. Nigeria has the largest burden of soil-transmitted helminths, which are the statistics are given for the major three ones, Ascariasis, hookworm, and Trichuriasis. No country anywhere has more cases of Schistosomiasis, about 29 million, than Nigeria. Nigeria has the greatest number of people infected or at risk with lymphatic filariasis. The figure is there. 27 million people need protection against river blindness, and this is also more than in any other country in the world. Nigeria is working with several partners, as listed there. There's the USAID and DFID, and then a philanthropist, T.Y. Njuma, has led the engagement of private sector into the fight against NTDs. The other organizations that are involved, and many more others, some of them are listed there. There's a national policy on NTDs in place. The policy statement is that the Federal Ministry of Health will coordinate the control of NTDs in collaboration with NGDOs, United Nations agencies, and other relevant stakeholders and the private sector. The strategic goals for the NTD program is progressively to reduce morbidity, disability, and mortality using integrated and cost-effective approaches with the view of eliminating NTDs in Nigeria by 2020. Health officials, the mapping of NTDs. Health officials in Nigeria were trained by a team of international experts. So having maps showing the distribution of different NTDs is important for advocacy programs and implementation. And this will also serve as a tool for control. Data on the geographical distribution of NTDs are required in scaling up interventions, targeting treatments to areas of greatest need. Mapping of NTDs could also facilitate the process of scaling up interventions. This process requires that epidemiological surveys be carried out and maps generated to visualize endemic areas for planning interventions. Only onchocerciasis and guineum disease have been fully mapped. All the other NTDs are still being mapped in some parts of the country with varying levels of completion. There is the need to control integrated mapping baseline surveys for these NTDs so that mass drug administration and other diseases can be co-implemented. The proposed integrated mapping and baseline surveys of these LTDs will provide a unique opportunity to collect more comprehensive epidemiological data on distribution. The focus of these infections can be controlled or eliminated through community chemotherapy, health education, control activities, which can easily be integrated. So I'll take the diseases quickly one by one. Onchocerciasis, it's present in almost all the states except 3. It is estimated that about 31 million persons are infected. Onchocerciasis control program has been in place since 1987 with the mandate to reduce prevalence to levels which it will no longer constitute a public health problem. In 1991, chemotherapy of communities with ivermectin was commenced. In 1997, the CDTI strategy was adopted as the main strategy program. program implementation. Lymphatic filariasis, Nigeria is the third highest with lymphatic filariasis burden, but it has not yet started mapping the disease. About 106 million Nigerians are at risk. There's a national lymphatic eradication program. It was later merged with the national what was that? Okay, it goes together with the National Onchocerciasis Control Program for the MDA distribution in co-endemic areas. In 2003, the NLEFP started mapping in the country. So far, about 30 out of the 36 states and the federal capital have been completely mapped using immunochromatographic test cards. Lymphatic filariasis, the prevalence has been determined in some states and local governments, 704 out of 777. Out of this, 541 are endemic, while 164 are not. Presently, 21.6% of endemic LGAs are under MDA with free donated ivermectin and albendazole tablets. The partners are listed. Schistosomiasis. Nigeria also has the highest burden of this disease in Africa. About 116 million are at risk. The National Schistosomiasis Control Program was initiated in 1988, and it is to distribute drugs to at least 75% of school-age children in endemic areas. And this is in line with the WHO recommendation. The control strategies are listed there. There is no national program in place for schistosomiasis. But there's a Carter Center. It's a non-governmental developmental organization which is implementing integrated control of schistosomiasis and other NTDs in 2 states in Nigeria. Integrated mapping baseline surveys have been conducted in only 19 out of the 36 states. The national program got the first donation of tablets of parazicontile from the WHO in 2009. Soil-transmitted helminths, the program for them started in 2007 in line with the WHO recommendation. Antihelminthic drops are to be given to at least 75% of school-age children in endemic areas and those that are at risk. The mapping for STDs has been for a total of 190 local government areas in 16 states. The collaborating agencies are listed. The program is also collaborating with WHO, Merck Pharmaceuticals, PCD, Deworm the World, and so on. So morbidity control is by using chemotherapy, mebendazole, albendazole, at targeted school-age children. Collaboration with appropriate stakeholders for the provision of adequate sanitary facilities, potable water, and improved environmental sanitation is also going on. Partners for the national, I think this is out of place, human African trypanosomiasis. This was first reported in the 1960s, and a few cases have been reported, but there's no confirmatory diagnosis going on. Some cases are still being diagnosed, but which means there's an indication that heart is still endemic in Nigeria, and there's the need to eliminate it, but there's no control program for it. Dracunculiasis. Nigeria used to be the third top 3 endemic country in the world when the Nigerian Guinea eradication program was initiated in 1988, which coincided with the decade for the supply of water, for drinking water and sanitation decade. Nigeria reported over so many cases in the past, but the prevalence is reducing. In 2008, a 99.9% case reduction was recorded, and transmission has since been stopped. 0 case status has been reported, and now the Nigeria is in partnership with the Carter Center and the Yakubu Gawan Center are working on the certification for guinea worm in Nigeria. So many strategies were adapted. I'll just skip them. Leishmaniasis. Okay, now there's even a cash reward that if anybody should come across anybody with guinea worm, you should report, and then we'll be given a cash prize. This has been on for some time, and we've not had anything. So I think we are going close to certification of the disease. Leishmaniasis. In Nigeria, the endemicity of Leishmaniasis is not known, except maybe in some few research articles. There's no focused control program for that, and there's no mapping. Loasis it has also been reported in some areas, some of which are also endemic for onchocerciasis. So the mass drug distribution is for the 2 diseases in areas which are co-endemic. The only thing that looks like diagnosis is by identification the eye. You know, the loasis is the eye worm. So when people go to the area and they have a picture of the eye worm, and then people who see it, who know it, will say yes, and then that will indicate that it is present there. So, or even the history of the worm can be regarded by use of photographs. Another NTD is trachoma. Nigeria lies in the trachoma zone and is the second major cause, which is a second major cause of avoidable blindness. The population at risk is about 12.5 million. An estimate. A national blindness survey was completed in 2007. The trachoma control plan is designed to take a few steps at a time and gradually expand. These are the partners that are involved in the elimination of trachoma in Nigeria. The implementation is based on the SAFE strategy, which is surgery, antibiotic use, face washing, and environmental improvements. Leprosy. Nigeria is still one of the leprosy endemic countries in the world. Presently, it has combined TB and leprosy program together, which has become operational in 1991. Since then, a total of 111,788 leprosy patients have been successfully treated with MDAs. In 1999, the country achieved the WHO elimination target of less than 1 case per 1,000. The implementation of these policies at the state and LG levels have been well arranged, and it has been integrated into the national health system. Bruley ulcer, this was first reported in 1967 and is still in an emerging phase. Its elimination has been controlled, has been added to that of the tuberculosis and leprosy. Current situation, streptomycin and rifampicin have been supplied by the WHO, and these were distributed. There is the evidence that Bruley ulcer is gradually increasing. There is also the need to obtain basic data to help plan effective Bruley ulcer control as a vital necessity to conduct mapping for the disease. Rabies. In Nigeria, there's no data on people infected or at risk with rabies. Little is known about the distribution or the endemic foci. So there's also the need to do the mapping and to obtain baseline data. This table shows the mapping status of the different NTDs in Nigeria. The next table is a summary of the information on existing preventive chemotherapy programs that are being implemented, the NTD, the program, when the program started, total number of LGS targeted, total LG, the geographical coverage, and so on, up to the key partners in the control program. The third table is for case management for all the NTDs. Yes, this one table is divided into two. Some of the MTDs are co-endemic. You find 2 or 3 of them in the same area. So this map is showing the co-endemicity of NTDs in Nigeria. They're identified by different colors. Now then, how combating NTDs? Many, like I said earlier, there are many partners in this. Site Savers is tackling onchocerciasis and filariasis in 3 states. And their support will protect 2.5 million people per year. And this will reduce the burden of the blindness and lymphatic filariasis. The United States support for NTD in Nigeria was initiated in 2012. And the first USAID and DFID visit to Nigeria was in July 2012, when it met with the federal government and key stakeholders to determine how best to support the NTD, National NTD program. USAID and DAFRI have agreed to collectively provide approximately $36 million after 4 years, funding to support efforts to document nationwide disease prevalence, mass treatment and programs training, monitoring and evaluation. This is what the fund will address. Then it will also support the Ministry of Health to closely coordinate the USAID and DFID support to the Ministry of Health is closely coordinated through the Aviation Project and the DFID, and currently covers about 13 out of the 36 states. The impact of USAID and DFID funding is dramatically increased by generous drug donations from Merck and Serono. Then about a year after the London Declaration on NTDs, Nigeria was cited as a model by setting out its national plan and by inviting support from global partners. The control of NTDs in many sub-Saharan African countries have been made less important by other health priorities, with the highest priority given to HIV, AIDS, malaria, and tuberculosis. What is needed for the control of NTDs is very small when you compare it to what is spent on these 4 diseases, which are regarded as major or maybe more important. A small amount of the money required for this will be enough to take care of the NTDs, but government appears to think that these are more challenging. Control activities for onchocerciasis. Okay, it's time. Okay, the next is just control, how the strategies for the control of the different NTDs. But the best is the integrated control, where a number of diseases will be taken at the same time, and then if it's mass drug distribution, it will be done at the same time, and so on. So this integration of control measures will be cost-effective. There are certain strategies that are used. I have listed them there for each of the diseases. I'm sorry, I have too many slides, so I'll just go to the last 2. The unmet diagnostic needs include mapping out, there is the need to conduct integrated mapping and baseline surveys for all the NTDs, and NTDs which are co-endemic should be mapped at the same time. Health officials should be trained on the mapping of NTDs. There's the need also to complete the documentation on prevalence and strengthening of NTDs nationwide. Innovative approaches need to be introduced. This may include encouraging community health programs, empowering community-based programs to take responsibility of activities such as drug administration, creation of awareness, case management, reducing transmission, health education and promotion, and so on. Now, the challenges and the practicalities. I strongly feel that Nigeria should work towards producing enough drugs for the diseases that require MDA, rather than depending on international organizations. More of the private sector and the NGDO should be encouraged to participate in the control of NTDs. And funding should be sourced by the Federal Ministry of Health for nationwide prevalence on all NTDs, mass treatment, training, monitoring, and evaluation programs. Thank you.